Developmental apraxia of speech. Developmental apraxia of speech, sometimes referred to as childhood apraxia of speech, is a speech sound disorder that affects the motor and sensory system of the brain. It typically presents with inconsistent speech patterns, difficulty segmenting syllables, and errors in prosody or the child's rhythm when producing speech. The cause and characteristics of the disorder are not agreed upon by researchers. The prevalence is estimated to be 3.4 to 4.3% of the United States population. Many researchers believe the disorder is manifested genetically, with high rates of family transmission, which means the disorder is passed down from family members to kin. In a study conducted by Lewis et al., 86% of individuals diagnosed with DAS had at least one nuclear family member that was also affected. Caddis et al. Discovered that children diagnosed with idiopathic apraxia had significantly thicker left posterior supramarginal gyri. However, Strand et al. Noted that it is still unclear in what way or what degree these areas, which include the basal ganglia, cerebellar circuits, proprioceptive feedback mechanisms, along with motor planning areas of the cortex, are involved in the speech praxis deficits. Children diagnosed with DAS show a higher variability of tongue-tip movement trajectories and a larger contribution of the lower lip relative to the jaw in oral closures. The variability in DAS children may indicate that the speech movements may be less established and/or delayed. The increased movement may be an adaptive strategy. Sensory issues in DAS are related to phonemic representations that fail to manifest completely. Sussman and Mark discovered that children with DAS reveal a striking inability to recognize and produce rhymes. This led them to believe that speech motor program deficits could not stand alone to describe such a phonological incompetence. DAS is described as comorbid, or having characteristics or disorders that present simultaneously. Lewis et al. Found that comorbid reading, spelling, and academic difficulties are present. Schreiber et al. Described the three most documented characteristics in DAS as struggle, groping, and trial and error behavior on production of some or all phonemes, inability to volitionally produce an isolated phoneme or sequence of phonemes that have been produced correctly on other occasions, failure to achieve on command isolated and sequenced oral movements available at an automatic level. Groping traits can take two forms: static state of articulatory position that occurs without vocalization, or searching for articulatory posturing during sound productions in an attempt to find the desired position for the articulators for proper phoneme production. Dodd and McCormick found that children diagnosed with DAS were found to have deviant phonological patterns and inconsistency in phonological errors. Categorizing symptoms is difficult because they vary drastically, are highly individualized, and evolve over time. Turban stated that symptoms can begin with little or no canonical babbling and less variability in babbling in the first year of life, along with slower expansion of their vocabulary during the second year of life. Apraxia in itself is defined as a symptom cluster, making it even harder for clinicians to distinguish a child from DAS with other speech sound disorders. Recent research argues that consonant errors affecting syllable structure, such as syllable reduction or initial and final consonant deletion, are more common in DAS than in speech disorders not identified as DAS. Most common errors in speech output include omissions, substitutions, final consonant deletion, initial consonant deletion. According to Mark, Sussman, Snow, and Jacks, children with DAS have a difficulty performing syllable tasks, including awareness of syllables, identifying the location of phonetic differences, and constructing syllable shapes. Another characteristic that is greatly affected in children with DAS is prosody. Children with DAS exhibit difficulties with intonation control and prosody, which can make the child's speech robotic and unintelligible. This would cause errors related to lexical stress, which ultimately changes the prosody of speech outputs. A complete assessment would begin with an extensive case history of the patient, which describes the phonemic and phonetic inventories and administration of oral structural functional examinations, and administering a number of articulation tests and or measures of phonological performance. Motor speech examinations are valuable tools in assessing things such as consonant and vowel errors caused by lengthening and or distorted movement transitions, dysprosody, timing issues, and inconsistency across repeated trials. The dynamic evaluation of motor speech skills is an assessment tool designed to specifically examine the speech movements of younger children and/or children who are more severely impaired. It uses dynamic assessment, which allows for numerous attempts of targeted utterances with cues or other strategies from the clinician. Cueing in dynamic assessment has the potential to facilitate judgments of severity and therefore prognosis, as well as facilitate treatment planning. Another assessment tool has recently developed is called Tabby Talks. It's an automated tool that contains modules to detect voice activity, pronunciation verification, and lexical stress verification. It uses automatic speech recognition, and its goal is to identify errors in the child's speech that are associated with the key behaviors observed in DASS. It is successful in identifying the main error types in DASS, which were voicing delays, pronunciation, and prosodic errors. Treatment. McNeil et al. Mentioned the top 4 traditional intervention strategies used with DASS, which include use of multimodal cueing for articulatory placement, use of drill-based exercises, use of imitation, systematic progression from simple to more complex sound production. Integrated phonological awareness approach incorporates targeted speech production practice with phonological awareness activities and uses letters and phonological cues to prompt speech production. Augmented and alternative communication devices allows for increased academic success and confidence in initiating conversation. Instead of traditional DASS therapy techniques that heavily focus on fixing articulatory proficiency and supporting speech through the use of sign language, a multimodal AAC approach provides the child with greater opportunity for communicative success and flexibility in participation, initiation, and repairing communication breakdowns. It has been shown to increase receptive language skills, confidence, and intelligibility. Verbal motor learning techniques are used to help define prosody in children diagnosed with DASS. Distal dynamic stabilization technique reflected dynamic stabilization of movements of the jaw. The child's intervention strategies were to decrease loudness of his voice, reduce word duration, and to achieve expressive segregation between high and low pitch. In only 4 weeks, the child showed significant changes in decreasing his word length, lowering his maximum loudness of words, and lowering the maximum frequency of the words. Conclusion. Overall, developmental apraxia of speech remains highly controversial in almost every aspect of the disorder, from its etiology, its symptoms and characteristics, and the validity of tools used for assessment and intervention. It most frequently is characterized by inconsistent sound errors, difficulty sequencing syllables, and errors in prosody. However, there are many other characteristics that have been discovered and a high variability of severity, along with evolving symptoms as the child develops, that make understanding and treating the disorder difficult.